now start today's program, a virtual program on of UCD. Today we have two topics. One is a case presentation, CTO step by step by Dr. Arindam Pandey. And second one is a discussion on fluid management in critically ill patients with HFrEF and intensivist's perspective, to be taken up by Debojyoti Dotto. The first topic being the CTO step by step. May I request Dr. Arindam Pandey to start his talk?
Okay, sir. Thank you very much. Respected seniors, my teachers, let us start the ball rolling. So what I'll do, I'll show you a few cases of CTO, which was done by me in recent 1 year or so that we can some idea how we actually should proceed for CTO intervention. Now, CTO, there are many confusions, many debates whether we should try to open CTO, whether it is beneficial for the patient. But let's talk about fact. The majority of the patients who are sent for bypass surgery, they have some kind of CTO, at least one or two CTOs. So if we start doing appropriate CTOs, then probably we can give a better, more cosmetic revascularization option for our patient who actually needs revascularization. Yes, probably all CTOs should not be opened, but there are CTOs which actually benefit. I'm not here to talk about that, whether it is rational to go ahead with CTO intervention. Rather, I would be showing some important steps which should be followed in all the CTO intervention. Now, I'll start with giving thanks to Professor Gerald Warner. I had been recently to his center for hands-on experience. He is one of the pioneers of CTO intervention. In fact, the retrograde collateral classification is on his name, Warner's classification of retrograde collateral. He is one of the finest CTO operator I have ever met personally. So few of my slides in this presentation actually are from Dr. Gerald Warner. So let us start the ball rolling. I'll first go through few important steps, or rather important techniques of CTO intervention, so that the cases which I'll show will make some impact, particularly for the youngsters, because this particular seminar are attended by many young individuals who are starting their career or who are actually students in intervention cardiology. So first technique is antegrade dissection re-entry, known as ADR. Now, as we all know, there are different techniques. Mostly we go ahead with antegrade wear escalation, parallel wear technique, which the techniques actually are being done for a long time. We have good experience, but now CTO intervention, there are few newer nomenclature, newer techniques, which I'll briefly show in the initial part of my slide. So one of these is the antegrade dissection re-entry. It is a very favorite technique for the American operators. So here, if you cannot open the CTO in the conventional way, so idea is to create a path around the blocked facial wall. So you can use a device or wire to pop back into the true lumen past the blockage re-entry. So why? Because this will provide a detour when you can't cross the CTO directly. Now, there are different newer devices, particularly one device I'd like to mention here is the Boston Scientific device. That particular device is now approved for CTO intervention, but it's a very costly device and it requires, operator skill. So Stingray balloon, I'm talking about. Stingray balloon is a good device for this particular technique, but I am not going to show that because I don't have any personal experience of using Stingray. Now, next technique is basically BASE. BASE means balloon assisted subintimal entry. So it is used when you need help to enter the subintimal space. As I mentioned, sometimes you cannot go through the CTO segment. It is so calcified that the proximal cap you cannot pierce. So there we try to go through the subintimal place, then come back to the true lumen. Sometimes it becomes very difficult to go to the subintimal space, and if you do not direct it in a proper way, then it can cause perforation. So this is one of the technique where what you do in the main primary wear, which has gone up through the CTO cap, you take a balloon, inflate it so that your second wear do not go to the CTO segment, rather it passes to the subintimal place. So inflate balloon, a balloon is inflated to open the space just outside the blockage. The wire and device can then move forward into the new channel. So why it is needed? Because it is helpful when true vessel path can't be entered directly. So this is the second technique known as BASE. Now, next technique is BAM or balloon assisted microdissection. Now, this is one of the technique where when we actually cross the CTO, but our balloon is not crossing. So this is also known as granuloplasty, where a small balloon is taken as deep as possible into the CTO segment. Then we actually rupture the balloon by going supra-threshold pressure. So this will create a tiny entry point space and help the wire or device advance when stuck. So this is one of the technique known as BAM or balloon assisted microdissection. Now, CART is very, well known nowadays because a lot of the CTO operator, they are doing retrograde CTO intervention. So CART full form is control, antegrade, and retrograde subintimal tracking. To be very honest, CART nowadays we are not doing, because here you can see the in the technique, you take a wire antegrade which has gone halfway into the CTO segment and a retrograde wire. Then we are taking a balloon through the retrograde wire and inflate that. So one side of the balloon is open so that it will create a common space so that our wires can meet. But here, taking a balloon through the retrograde wire is sometimes difficult, and it is sometimes dangerous because it might cause dissection to the retrograde channel. So generally, the thing which we are doing is known as reverse cut. This is very similar. The theory is very similar to the cut, but the antegrade balloon is used to make the space longer. And the retrograde wire then slips into the space and connects to the CTO segment. So this is known as reverse cut. It is very important. If you are doing retrograde, then you should be very much accustomed with the reverse cut. Now, the final technique which I'll show is common technique. We do it many a time. We many a time have done it without our knowledge, but this is known as STAR or subintimal tracking and re-entry. So where intentionally travels into the subintimal space and re-enters distally. So here no device is used, just the wire. So if the balloon is out, then nothing else works. Also, it can, work as an investment process. Nowadays, a lot of operators, CTO operators, what they do CTO in two stages. First is investment. As much space is created, they make some dissection and all. Then after some time, maybe 1 month or 1.5 months, they again take the patient, and this time, second time, the CTO intervention becomes easier. So it is known as investment. This is again very famous, popular among the American operator. So subintimal plaque modification, as I mentioned, you can do it. There are some devices which are available, but you need proper training to do this. So with that, let us start with the cases. So in my presentation, I'll try to show you some newer techniques, some newer catheters, which we are using in our day-to-day CTO intervention. So this is one such intervention where I used one of the micro catheter, which helped me a lot. So coming to the patient history. So my patient was a 48-year-old gentleman. He's a known diabetic and hypertensive, had a ACS 2 years back. Now he comes with refractory angina. The vitals were stable somehow. The heart rate was little on the higher side. Sugar was not properly controlled. So Echocardiography was done, which showed ejection fraction of 52% with preserved wall thickness of the anterior wall. There was changes in the anterior wall. Basically, this was a very old anterior wall, more than 2 years old. The patient was advised angiography followed by revascularization, and this is the angiography. You can see the LAD is totally occluded from the ostium. And this is a very long segment CTO and probably a second CTO, dual CTO. You can see the retrograde collateral from the RCA filling the mid portion of the LAD. There is a large collateral. But the problem is it is filling the diagonal, but distal to this septal, there is another segment which is again occluded. So probably there is two segment CTO and the proximal segment is very, very long. And it is flush cut off from the ostium of the LAD. So this kind of, CTO, sometimes it is very difficult because you never know where to poke. So better they are tackled retrograde way, but problem in this case was this was a dual CTO. So even if we go ahead with the retrograde technique, then again it might be difficult to open the second CTO segment. So this was really a hard CTO. Normally we calculate JCTO score, but always JCTO score may not give you a appropriate idea how difficult is the CTO, but this was definitely a difficult CTO. So one of the technique which is suggested in this kind of situation is to go ahead with IVUS guided entry. So you take an IVUS to the side branch and take another wire with the help of a microcatheter to find out which area is the origin of the LAD and then poke in that area. So that helps. So this is how we went ahead. We thought we'll take a microcatheter, then try to poke the area, which is probably the origin of CTO. This is a fine cross microcatheter, which is most commonly used microcatheter. And this is a Fielder XT-A wire. But problem you can see every time we have given a large, bend to the Fielder XT so that it goes towards the LAD. But problem is whenever we are approaching the CTO segment, we are trying to take the microcatheter to snugly fit it so that you can give more pressure. But every time it was going to the large, ramus. So that was a very big problem. We tried to, have an idea with the IVUS to exactly have the origin, which is the origin. We actually got the origin. It is very close to the ramus. But problem here was not to go to the origin or the CTO segment, but to have proper pressure and delivery of the torque. That was a big problem. So we thought this is going to be difficult. Let us change our strategy. So here I used one of the catheter, which is known as recross microcatheter. So this is a dual lumen catheter, but it has dual exit as well. You can see the end part, the blue one and the white one. Now you can see the tip has one opening and there is two exit port around 8 millimeter from the tip, then another exit pole at 12 millimeter. So this is the white one is the half tip lumen and this is the half stylet lumen. So if you take the wire through the blue, it will go through the tip. But if you take the wire to the white, it can either exit from this proximal or the mid port. And they are strategically exactly located to the opposite side, so 180 degree. So by that, you can actually manipulate the wire and direct your wire to a side branch. So this is how it works. It is very good for side branch, access and also very good for subintimal space re-entry. If you went through a subintimal space, then if you want to come to the true lumen, there also it helps. But you need to take the catheter down, very down to the subintimal space so that the true lumen is actually there. So you use this, catheter. It is little expensive catheter, but you can see how it was used. We have taken the, first wire to the ramus, then the second wire. You can see the second wire. how we are taking. Initially, the second wire went to the circumflex because it was going to the mid portion, probably the proximal mid portion. Then we withdrawn, give a 180-degree torque. Then it went to the exact location where we wanted to negotiate the wire. And now the Fielder XT, you can see, made some progress. It has gone inside the CTO segment, though it was a very long CTO segment, but at least it is to some extent entered the CTO segment. But the problem here again, you cannot give good amount of torque delivery or pressure because again it was flipping to the large ramus. So what we did at this point, we removed this microcatheter. The purpose of using this recross microcatheter is successful. It is over. Now we exchanged it with a normal fine cross microcatheter. You can see we have exchanged it to the fine cross microcatheter with balloon trapping technique. And after that, you can see we could actually wear the LED up to the mid portion. As I mentioned, it was a dual CTO. So again, we had issue in the mid portion. It was not going up to mid portion. It could actually reach. And our strength and backup support is also good. So I forgot to mention, we went through a femoral access, 7 French EBU, so that we have good backup support. And also we are planning to use multiple devices. So we need to have at least a 7 or 8 French guiding catheter. And you can see it has gone up to the mid portion, but after the mid portion, it is again going to a subintimal space, the Fielder XT wire. So we, withdrawn it, did some maneuver, and ultimately we actually could reach to the distal segment of the LED. It was a very big type 3 LED. Then we exchanged the Fielder XT wire with our standard workhorse Yon Blue wire. Then it was usual steps, serial predilatation, initially with a small balloon, then with larger balloon, then deployment of 2 drug-eluting stents. And this was the result. So serial post-dilatation. And everybody will appreciate the large LED. The distal segment probably is underpinned, but I'm sure it will grow. And very interestingly, the proximal large ramus and non-dominant circumflex were flowing very nicely. So this was the first case where a new catheter was used, known as recross catheter. Then I'll show you the second case. Again, this was a male patient, 56-year-old, history of MI 6 months back. Not a very old MI, vital stable, ejection fraction 44%. He was having significant post-MI angina. So we planned for revascularization. Actually, this patient was, taken for revascularization in another center. There they found a totally occluded LED. They wanted to do the angioplasty, but they failed. So we actually had the CD from outside. This is the CD. You can see a very good collateral, but antegrade also was not a very long segment CTO. And there was some probable faint flow from the antegrade segment. So we thought probably if we do a proper job, we can open it antegradely. But to our utter surprise, every time we took antegrade wire escalation, even we went ahead with parallel wire technique, we could not wear the LED. And again, this was a big LED. So we gave a reasonable attempt of 1.5 hours, but ultimately we could not wear the LED from antegrade route. So we decided to went ahead with retrograde. This is a Corsair flow microcatheter and a Sion wire, Sion black. And the antegrade wire which went into false lumen, this retrograde wire, initially we took, then we changed it to a Gaia wire. This is a Gaia 2 wire, but they were meeting, but none of the wire was crossing. So we thought let us go ahead with the reverse cut technique, which I already mentioned in the initial part of my presentation. And you can see the after reverse cut, what we did. This is for wire externalization, because we could reach to the proximal part of the LED, but to make it easier, we use the GuideZilla, which is a guide extension, so that our retrograde wire could actually easily be externalized. And that is how we did it. Now we can see we have wire exchanged. We extend it with a RG3. Then we did, IVAS showed our proximal wire actually was in false lumen, and this is the picture of cut. But the problem started after even the proximal dilatation. We could not reach the distal segment of the LED, because every time the wire was crossing to the large septal collateral. So here again we used a dual lumen catheter known as Crusade. You can see the Crusade, and then we did serial dilatation and 2 drug-eluting stent deployment. IVAS optimization. Somehow we, after 2 stent deployment, we observed some funny kind of opacity in the proximal part, distal part of the left main. So we also stented the left main. We did IVAS, it showed some dissection. Probably dissection had went into the left main, but we stented it. And after that, this was the final result. The shark was flowing. The ramus had some issues, but it was not a very big ramus. So we thought, as it is a flowing vessel, we will not do further things. And this was the final result. You can see the large LED has opened. The third case, which I'll show, I'll actually show four cases. The fourth case actually is not a CTO, but it's very interesting. So I thought I'll show that. So third case is a case where nothing was crossing. Again, a very significant angina patient, symptomatic despite using 5 anti-anginal, normal ejection fraction, concentric LVH. This was the left system, minor plaque. But you can see a retrograde. And RCA was totally occluded with bridging collateral. Good part about the story, the CTO segment was not very large, long. We thought we'll open it. So we went ahead with antegrade wire escalation technique. Initially, we took a AR catheter because we had some issue in engaging the RCA. So we thought AR will be a better option than AL. So we went ahead with 7 French femoral access AR. So fine cross microcatheters. Initial wiring, we thought we'll try with wire escalation. So Fielder XT, but Fielder XT did not cross. So we took Gaia. This was a Gaia second wire. And with some manipulation, initially it went into this false lumen, but ultimately we could reach the true lumen. Now, problem started after that, because even after crossing, we could not negotiate balloon through the CTO segment. So this was a case where CTO could be crossed, but balloon was not crossing. Initially, we tried with 1.25 Ringi, which is a very good balloon. We tried with Nick Nano, which has a profile of 0.75, but nothing was crossing. So at this time, we tried to increase the backup support with mothering child, that is GuideZilla, but still we can see the balloon. We tried granuloplasty. A 1.5 balloon was busted, but still it was not making space. So at this point, we thought, let us try anchoring balloon technique, because there was a branch. Initially, we wired it, but while trying that, our whole system came out. So even the wire which went, we lost the access. So we thought, let us increase the backup support further. We took a 7 French AL1 catheter, and second time wiring was not a problem because we already had some passes, so we could wire it easily with the Gaia second wire. So we thought, let us use another microcatheter known as Tornus. Tornus is like a drilling machine. It has given success in many of my past cases. So this is used for a case where your wire has crossed but balloon is not crossing. You give 15 clockwise rotation, then release, then again go ahead. But in this particular case, you can see the Taurus also made some progress, but it could not cross the CTO segment. So all our efforts failed. So this is the stepwise approach when we're in for the balloon uncrossable lesion. So small balloon wedge technique, balloon assisted micro dissection known as balloon granuloplasty we tried but failed. Increased support with guide catheter extension. We used guide GILA but failed. Microcatheter, wire exchange, Tornus microcatheter, anchoring balloon, but everything failed. Now we have option of using laser, but in my hospital, we do not have the option of laser. So only option which is left is the atherectomy. Now using atherectomy here is little tricky because there are possibility of dissection and perforation because at some part of the CTO segment, you might be extraluminal, the subintimal space. So we had a detailed discussion with the patient's relative and went ahead, patient relative gave consent. Then we went ahead with the rotablation. We exchanged the wire because wire crossing this time also was not a problem. We could not cross the microcatheter, but we directly took the rota wire. This was a rota floppy wire. It somehow went. Then we took a 1.25 bar and did rotablation of this segment. So after rotablation, things were easier. You can see the flow has achieved. That flow is achieved. Then we did serial pre-dilatation, semi-compliant, then cutting balloon. And this was the result after cutting balloon pre-dilatation. Then DES deployment. And this was the result after DES deployment, post-dilatation with a 4 millimeter balloon. And this was the result. So very good antegrade flow, you can see. Now the last case which I'll show, this is actually not a CTO, but a very interesting case. This was a poor 59-year-old male. He had history of bypass surgery with aortic valve replacement in 2010. Also had history of renal angioplasty in the same year. Also had history of angioplasty before the bypass surgery and AVR, LCX in 2009. Somehow he became symptomatic and his graft was seen to be occluded, lima graft and all. So he had redo bypass surgery in 2023. Now after redo he was doing good, but after again 1.5 years he started having symptom, significant angina, shortness of breath. So we went ahead and did the angiogram. So this was the OM bypass. This was a left dominant circulation. The graft to the OM was flowing, but the graft to the LAD was having significant stenosis. This was the graft which was, done in redo surgery. So just 1.5 years back. So this has significant issue. So this was a patient from Bangladesh. So now Bangladeshi people, they have a lot of issue, for their stay, visa, and always this kind of patient are having, as their cash patient, they have significant issue with the money. So we advise for, angioplasty to the saphenous venous graft, but they got discharged. They, told they will arrange money. They had, finished the visa period. So they came after 2 weeks. Again, significant angina, but this time the problem was, now this was the angio. So PT says to stenting to RSBD to LAD was planned, but due to monetary issue, they came after 2 weeks. Now, when we took him again for the angioplasty, we could not see any flow through that venous graft. We took a pigtail, you can see there is hardly any flow, no flow at all in the saphenous venous graft. And the native LAD was so bad, you can see it was very difficult to approach. So you can see the native LAD, it was very difficult case to go ahead. There was very thick calcification. We thought we'll give a try to the native LAD because we could not find the SBG graft. But somehow before doing that, we thought let us take a shoot to the RCA. This was a retrograde shoot from the non-dominant RCA. We could see the graft actually was filling. And you can see the graft was filling to the retrograde, non-dominant RCA, and it was filling up to the very proximal part of the venous graft. So this somehow increased our, curiosity. So we thought, let us taking that, there was some dye holding. So taking that as a, marker roadmap, we went ahead blindly, took a AR catheter and then wired it. It was little difficult, but we could wire it. You can see the wiring is done. Then we did a very aggressive predilatation of the proximal portion of the saphenous venous graft. It was very difficult because probably there were some switches. So we had opened it with ultra high pressure balloon of OP and MC 2.5 at very high pressure. Then serial predilatation. And this was the flow after predilatation. You can see the LED. It was a big LED, totally occluded. Then took a 4 millimeter stent, deployed at 20 atmospheres. And this was the result. The procedure is done around 6 months back, and the patient is doing good. This was the final result. So with that, I stop here. Any questions, comments are welcome.
Thank you, Arindam. Excellent cases. Perhaps, at least personally, I will never venture, to be very honest, being a little more conservative. But it is open for discussion, and let us hear from our younger colleagues what they feel about these cases. Anybody? Anjanda, any comment? Anjanda, can you hear me? Anjanda is perhaps can't hear. Avik? Avik, are you there or just joined and pushed off?
Am I audible?
Yeah, now you are audible. Good.
It was a fantastic procedure, no doubt about it. The newer technologies and everything is there. But I just want to ask Dr. Pandey whether before you go for the procedure, while doing the angiography, do you have any particular methods or particular ways? Because after all, imaging is very important to plan your ways of technique. So do you need a high speed velocity angiography or any particular precautions or particular procedures so that the imaging is helpful in the procedure?
Yes, sir. Extremely important point. So as I mentioned, I was there in Dr. Gerald Warner's center. So I observed few points. Anybody who really want to be good CT operator, probably they should listen. So what I observed, ideally you should be doing CTO intervention in biplane machines so that your dye requirement is lesser, your fluoro exposure is lesser. Dr. Warner was doing all the procedures in fluoro-save mode. He was hardly doing any cine angiography. And very interestingly, he was reducing the frame rate to 7.5. So it's extremely important to reduce the radiation exposure. Always the nurse and technician was there to warn about the radiation, how much radiation you have given, how much dye you have used. So all CTO intervention, it is mandatory to, not give antegrade injection, particularly if you are planning to do retrograde CTOs. So antegrade injection has to be avoided at all cost because that will increase the process chances of dissection. And nowadays, yes, angiographic, planning is extremely important. All cases, you just cannot go and start doing a CTO. You need to think about it. And none of the CTO to be taken as an add-on procedure. You should spend at least half an hour to all the angiography before we go ahead. We should, because you should have plan 1, plan 2, plan 3, plan A, B, C for all your CTO cases. And now I can see the importance of IVUS. IVUS has come in a big way, but the problem with the conventional IVUS, which we have in our lab, they are not front-loaded camera. The Boston Scientific IVUS. So probably the Philips IVUS, the Volcano, or the new IVUS machines which are available from Terumo or Assist. There is one IVUS which is known as Assist. They have front-loaded camera. So they are particularly useful for this kind of situation for IVUS guided entry to the lumen. So all these things you need to take care. The dye part, the fluoro exposure, everything has very important. And if you have facility, then probably you can go ahead in a biplane machine, which we do not have in our hospital.
Any other questions or comments?
Wish you good luck for a bright future.
Thank you, sir. My pleasure, sir.
Avik? হয়ে গেছে। Somnath? Anybody else? Anyone who wants to make a comment or ask a question?
Now, what is your experience, Arindam? Although we know different trials, ischemia trial, other trial, CTO is not a direct evidence of survival benefit. But what is your own experience when doing some cases? It may prevent them from doing a CABG. It may prevent them from developing a little bit of the LV dysfunction. Do you think there are some indications that there may be survival benefit as well?
Sir, there is huge debate in this issue as I mentioned. But if you see the CCS trials, none of the trials as of now has shown any benefit by doing intervention in chronic coronary syndrome. Now, this chronic coronary syndrome, if you do angiography, a large proportion will have CTO. So the same rule is applicable for CTO. Now, if the patient is having LV dysfunction, or the CTO location is very strategic. Say, for example, my first case was an ostial LAD CTO in a young person. So left main, ostial LAD or LV dysfunction. And if you can document that your muscles are viable, I'm not talking about I'm not going to debate of the viability study. There are many flaws in the viability study. But anybody who has significant angina, I strongly believe, they will benefit out of CTO intervention. I'm not talking about CTOs of the non-dominant LCX or the distal LAD CTO, but most of the RCA CTOs or LAD proximal CTO or Lippmann CTO, they can actually benefit. This is my personal belief. In terms of symptomatic improvement, yes, doing CTO intervention, there is a clear-cut evidence that it improves the symptom. So from that point also, it can provide benefit.
Quality of life.
Yes, sir.
Avik, I can see you now. Any question? Have you heard the talk?
I heard.
Any comments or questions?
না সেরকম তো নেই ইয়ার
এরকম কিছু নেই কারণ অন্য জায়গায় ছিলে
না না না
ঢুকে গেছি।
না না ছিলাম
কোথায় পড়াচ্ছেন ঘোষা
কোথায়?
Anybody else? Otherwise, we move to the second.
এই অরিন্দম দা ওই প্রথম যে মাইক্রো ক্যাথেটারটা দ্য ফার্স্ট মাইক্রো ক্যাথেটার দ্যাট ইউজড কি রিক্রস মাইক্রো ক্যাথেটার মানে ওটা এমনি প্রাইস কেমন ওটার মানে জাস্ট টু হ্যাভ অ্যান আইডিয়া
90,000 price. At
90
least in my hospital, 90,000.
recross. I have used crusade but this is the first time I've heard about that recross. So can we take 3 wires because there are 3 ports of
No,
exit.
2 wires.
There's
2
only
wires.
2 wires but the exit
একটা
port
টিপ
is
দিয়ে বেরোবে, সেকেন্ড ওয়্যারটা প্রক্সিমাল দুটো পোর্টের যে কোনো একটা দিয়ে বেরোবে, ঘুরিয়ে নিয়ে করা যায়, 180 ডিগ্রি ইতে আছে,
আচ্ছা বাট
অপোজিট
মানে
অ্যাঙ্গেলে আছে।
এক্সিট দুটো কিন্তু দ্যাট ইজ ফর অনলি ওয়ান ওয়্যার।
এক্সিট 3টে, এন্ট্রি দুটো, এক্সিট
আচ্ছা
3টে।
আচ্ছা আচ্ছা ওকে ওকে
ডাবল এন্ট্রি, ট্রিপল এক্সিট ক্যাথেটার।
আচ্ছা ওকে
Okay, then thank you very much, Arindam. Excellent cases. Technically, very, very challenging. But as Anjanda was asking, definitely it is going to give you some improvement in the quality of life. There is no question on that, because if the patient had angina and if you can establish a good circulation, certainly there will be some improvement in the quality of life. But unfortunately, we don't have any evidence whether there is any improvement in survival or anything.
Yeah, I do agree with you, sir. But many of these patients are actually going for bypass surgery. So you will agree that, if I can give him a better, less invasive surgery without any scar and future possibility of, I can keep the option of bypass surgery open. So that is definitely something we should consider.
Yeah, particularly for the younger individuals, you can defer the bypass surgery, definitely. That is
Yes,
definitely one point. And again,
Exactly.
in the post-bypass surgery, if you do some intervention on the graft CTO, that is also a beneficial rather than going for a second redo CABG.
Yes, sir.
Thank you very much. Thank you very much. We will move to the next topic, fluid management in critically ill patients with HFrEF, to be taken up by Dr. Debojyoti Dutta. Debojyoti, are you here?
Yes, yes, sir. I am here, just sharing the screen.
Please proceed with your talk.
So can you see my PPT presentation?
Yeah, it is visible.
Okay. Good evening, sir. I'm going to talk about one of the most challenging part we face every day in managing the patient of low ejection fraction critically ill cardiac patients in our ICU. So as you all know, the heart failure is a leading cause of morbidity and mortality, and the maintenance of optimal hydration status is very crucial because both overhydration and dehydration are detrimental. Though the patient with low ejection fraction more prone to develop congestion, but they can also present in certain situations in a state of dehydration or low circulatory fluid volume. So therefore, the management of fluid in this sort of patient is one of the biggest challenges we face in intensive care unit. So our goal always will be the maintenance of optimal hydration. So any changes from the fluid input or fluid output can land up into the overhydration and dehydration in this patient. So first I will go to regarding our dehydration and overhydration to spectrum and usual patients. So though there are certain symptoms and clinical features, we can differentiate between them. But when the patient land up in intensive care unit in critical phase, it's become very difficult to draw the line in between. Most of the time, you find the features, signs, and symptoms and overlap in between. There are certain non-invasive methods to assess the fluid volumes in the patients, like bioelectrical impedance, though I don't have in my ICU, but we use that ultrasound, CT scan, and bedside echocardiography to assess the volume status. Now, come to the most important and one of the most life-threatening spectrum of this disease is the cardiogenic shock. As from the symptoms point of view, we can see the left ventricular failure specifically has certain symptoms like hypoxemia, orthopnea, PNDs, and the right ventricular failure, they mostly present with the signs of systemic venous congestion. But end of the day, the both of it leading to the low perfusion pressure and multi-organ dysfunction. This is a classification of cardiogenic shock that we see. From the left hand side, you can see the perfusion signs of low perfusion. The right hand side, we can see the signs of congestion. In the classification, class 1 and the class 3, both are dry and warm and dry and cold. In this sort of patient, there may be a chances of giving some fluid if they are hemodynamically unstable at the point of time. But in the patient with wet warm or wet and cold, they are more prone to develop pulmonary edema or congestion. So fluid therapy may not be beneficial. Rather, we may need to take out the fluid. So for this reason, we need to assess the fluid status of the patient and fluid responsiveness of that patient. This is the usual that we all know, the Frank-Starling curve that here we can see. One is a normal cardiac output, normal ejection fraction pressure, and the below is a compromised ejection fraction pressure. If my patient is the steep part of the ascending of the Frank-Starling law curve, they can have some area of fluid fluid responsiveness, so that giving a fluid can increase the cardiac output. But in case of the compromised heart function, the improvement will be pretty less. So we need to be more cautious about giving fluid in this sort of patient. So the three terms I just want to introduce a little bit. One is fluid responsive and a fluid tolerant and fluid overload. Fluid responsive means the ability of the heart to increase the cardiac output at least by 10%. Fluid tolerant, where giving patient can accommodate the administered fluid without causing any organ dysfunction. Fluid tolerance comes between a continuum of fluid responsive and fluid overload. In between it, stage, any patient who is fluid intolerant, they are landing up into the overload, and where the fluid we have to take it out rather than giving the fluid. But in fluid responsive patient, we can give some fluid to augment the cardiac output. So this is a continuum. Here you can see the left hand side where the patient is hypovolemic or relatively hypovolemic. In low cardiac output patient, they can become hypovolemic due to the overuse of diuretics, decreased intake due to some other disease like infections, dementia patients, or they become hypovolemic because of the sepsis, relative hypovolemia. Later on, if we give the fluid, they can land up into the fluid intolerant and fluid overload. So we need to assess giving before the patient carefully. So the fluid responsiveness or volume responsiveness, as I already told, is giving a fluid increases the stroke volume of 10 to 15%. Even though there are many ways to determine the fluid responsiveness, the definitive way is to be giving the actual fluid challenge, where the giving a fluid will increase the cardiac output and oxygen delivery to the patient. This is a diagram. I just wanted to put it here. So how the fluid shift happens in our body. On the left hand side, you can see the large reservoir with the mean systolic filling pressure, then the stressed volume and the unstressed volume. The right hand side, you can see the right atrium and right atrial pressure. So usual circumstances, the volume of the blood volume that is taken part in usual circulation is the stressed volume. So in relative hypovolemia or hypovolemic phases, what will happen? The stress volume get reduced. So giving a fluid, we can increase the stress volume so that we can increase the gradient from mean systolic filling pressure to the right atrium and will increase the cardiac fluid. On the other hand, if you use some vasopressors like noradrenaline, the vasoconstriction, this will also increase the stress volume by reducing the reservoir size. So fluid administration leading to increasing stroke volume, based on two things, it depends. One is stress volume should increase the circulating filling pressure and increase the gradient of the pressure from mean systolic filling pressure to the right atrial pressure. Another part, my ventricles should be working at an ascending limb of the Frank-Starling curve, because otherwise it's going to lead to the fluid overload. So this is a schematic diagram of the same thing. So here you can see the normal heart and the failing heart. The ventricular preload in the x-axis and the y-axis is stroke volume. With the same preload, one normal heart has a fluid responsiveness, but in case of the failing heart, it becomes unresponsive. So assessing preload, that's why it's not assessing the fluid responsiveness. The static measures that we usually earlier used in intensive care unit, like central venous pressure, pulmonary artery occlusion pressure, IVC diameter itself, they are the static parameters. They cannot actually predict my patient fluid responsiveness. They can help us to estimate the volume status of the patient, but sometimes there are lots of interaction, lots of factors that affect the static parameters. Though the static parameters that usually that was used in CBP, pulmonary artery occlusion pressure, global end diastolic volume, and left ventricular end diastolic volume. They are actually snapshots of patient's hemodynamic status at a single point of time based on pressure and the volume. They are less sensitive and less specific regarding the fluid responsiveness, which is very dynamic in nature. So comes to the CBP, there is an age-old method to use to assess the right atrial pressure. So as the right ventricle stroke volume determines the left ventricular filling pressure, so CBP is an indirect measure of left ventricular preload. This is a assumption, and the patient who is truly or relatively hypovolemic will be expected to have low CBP, and CBP should increase in response to the fluid challenge. So that's called the delta CVP. If you give a fluid, the rise of CVP. Someone is hypovolemic, the changes will be small. One which is not a hypovolemic, rather fluid intolerant or overloaded, the changes will be much higher. So increase in delta CVP will be higher. But it is a diagram that is showing that how the change of CVP can happen if you give the fluid. So it was a conception earlier very much used by giving a fluid change in CVP so that find out whether my patient is fluid responsive or not. But nowadays it is not used because this relationship practically very less accurate. There are lots of factors that intervenes in between: venous tone, interthoracic pressure, LVRV compliance, geometry, etc. That's why it is right now measurement of CVP in intensive care unit is not the regular practice. Only CVP can help us with the extremes of values. If someone has a CVP of less than 6 or 5, it can increase the likelihood of fluid responsiveness, but more than 15, obviously, it will increase the chance of congestion. But in between the gray area, it is not at all helpful. Come to the pulmonary artery occlusion pressure. It is also a static pressure when we pulmonary West zone 3, when the pulmonary artery balloon is wedged and flow at flow 0, PAWP equal to left atrial pressure, left ventricular end diastolic pressure, which usually represent the LV preload. But PAWP and LV end diastolic pressure relationship is not equal all the time. It can be more than actual LV end diastolic pressure, like valvular disease state, mitral stenosis, mitral regurgitation, left to right shunt, COPD patient, positive pressure ventilation, pulmonary artery hypertension. It can be less than the LV-EDP, like LV failure, high PEEP, poorly compliant LV in that case. So now come to the LV end diastolic area, which is also correlates with the LV end diastolic volume, which is the preload of the left ventricle. But again, it is a static measure. In extremes of its value, like if it is less than 10 centimeters square or opposition of papillary muscles, like kissing ventricles, it can strongly say that patient is hypovolemic, you can give a fluid. But if it is more than that, we don't know whether my patient will be fluid responsive or not, or whether we need to take out the fluid or not. If grossly dilated, we can know that we can take out, we need to decongest the patient at that time. But gray area is significant, enlarged. Now, global end diastolic volume, it is a transpulmonary thermodilation technique. We can measure this. It is a volume that assumes the 4 cardiac chambers are simultaneously diastole. So it will measure again the preload of the whole heart. But it can give an idea about the volume status, but it cannot give us idea whether giving fluid will increase the cardiac output or not. The way it is measured. So as our static measures fail to give us any idea about my patient fluid responsiveness, there comes the dynamic variables. Dynamic indices are one is heart-lung interaction indices and the passive leg rising test or the fluid challenge test. So what is heart-lung interaction? So it's the idea behind is that more and more the cardiac output variation with the mechanical ventilation, more likely the patient is preload responsive. So, and this cardiac output can be measured directly or can be measured by other surrogate like pulse pressure variation, stroke volume variation. So dynamic variables are the access to patient stressors to predict how cardiac output will change after a fluid challenge. They are more accurate in predicting fluid responsive than static variables. So these are the dynamic variables or static variables used day-to-day in fluid responsiveness assessment. Now, in the normal physiology, like spontaneously breathing patient during the inspiration, you can see during inspiration, RV preload will increase, RV stroke volume will increase, and RV afterload is also increase, leading to, but the LV, the preload will decrease, LV stroke volume will decrease, and MAP will be decreased in the inspiration, but reverse will happen in the expiratory phase. So completely opposite happens when the patient is on mechanical ventilation due to the positive pressure given through the mechanical ventilation. This is the diagram showing the changes heart-lung interaction in the patient on mechanical ventilation, how it affects our cardiac cycle, how it affects the preload and afterload, and ultimately the stroke volume of the heart. So this is the diagram showing the changes that we can see from the arterial waveform, the pulse pressure, the arterial waveform in positive pressure ventilation, the pressure will be less minimum at the end of expiration because at that time no positive pressure is there and the pressure will be higher at the end of inspiration when the peak airway pressure in the system is very high. Similarly, velocity time integral of the left ventricular outflow tract is also changes like that. And IVC changes that we commonly see, it is minimum during the end of expiration and maximum at the end of inspiration. So coming to the dynamic variables, first is the pulse pressure variation. Pulse pressure is always, we know that's the difference between systolic and the diastolic pressure. And this difference is proportional to the left ventricular stroke volume and inversely related to the arterial compliance. So respiratory change in the LV stroke volume will be reflected in the pulse pressure during the respiratory cycle. So PP will be maximum at the end of inspiratory period and minimal at the end of expiration after the 3 heartbeat later. So its changes is calculated as maximum minus minimum divided by the average. If the variation of pulse pressure is more than 13%, it has shown to be very specific and sensitive indicator of the preload responsiveness. Here you can see in the steeper portion of the curve is a more variation, more responsive. In the plateau phase, the patient become unresponsive, variation is gone. Okay, so how this pulse pressure variations we can measure certain monitors like Philips IntelliVue that we have in our ICU with the arterial line, just to put an arterial line, they can give us the pulse pressure variation. Besides that, certain other machines like FlowTrack, our advanced hemodynamic monitoring like EV1000, they can also provide the pulse pressure variation is a continuous waveform manner, and also we can get it from there. Similarly, in the stroke volume also, so the stroke volume variation, the difference between the maximum minus minimum and the minimal values of stroke volume over a single respiratory cycle, the stroke volume variation. And if it is more than 12%, it has a very good sensitivity specificity to predicting the fluid responsiveness. In mechanically ventilated patient, hypovolemia has been shown to increase stroke volume, whereas the volume expansion will decrease the stroke volume variations. So arterial pressure waveform, it can also be calculated from the arterial waveform analysis directly. And also it can be calculated by the echocardiography if we calculate the velocity time integral, VTI and area of the aortic root. So stroke volume is calculated automatically by the cardiac output monitoring devices like Vigilio, EV1000, and other advanced monitors here. So this is the diagram showing the variation in stroke volume variation, pulse pressure variation, and also the systolic pressure variation. But these techniques has little drop limitations, like they are not very accurate in patient with the arrhythmia, patient who have a raised intra-abdominal pressure, patient on mechanical ventilation but on spontaneous breathing, or any other patient is spontaneously breathing, and patient who have a very low heart rate to respiratory rate ratio. In that case, it's become not very accurate. That's why we cannot use in this sort of those patients. Now comes to the most important is the fluid challenge. That is, we always sometimes we say in intensive care, it is a very common practice, give some fluid and see how the blood pressure response, how the urine output. So conventionally, it is a fluid challenge. Our goal is to increase the preload, and if this increase in the preload will increase the cardiac output of stroke volume more than 10%, we will say the patient is fluid responsive. Conventionally, earlier we used to give the 4 ml per kg of the volume in a short period of time, and after that monitor the cardiac output or other desired variables after 5 to 10 minutes. If it is a change is more than 10%, the patient is fluid responsive. The latter one is a smaller version came actually it's a mini fluid challenge. It is a very useful for the cardiac patient. Smaller amount of volume around 100 ml infused within a minute and real-time monitoring of the cardiac output. If it is more than 6%, patient is fluid responsive. So before giving the fluid bolus or fluid challenge to anyone, you need to follow these protocols. First, we need to decide what type of fluid you should give. Mostly we use a crystalloid. What should be the rate of the fluid? What is my objective? What I will observe? One is the normalization of macro pressures like arterial pressure, heart rate, and the microcirculation, or we'll measure the completely cardiac output. And what is the limit when you stop? Will not give. If by CVP increase more than 5 and PVPI pulmonary vascular permeability index increase or extravascular lung water increase will not give the fluid challenge. It's the difference between the conventional fluid challenge and the mini fluid challenge. So here is what is the drawback of fluid challenge? If my patient is volume responsive, we are giving a fluid challenge, see the changes is okay. We are giving again a fluid challenge. By the time we give the fluid challenge, ultimately we may reach to the end of it, like the plateau phase. But the drawback of fluid challenge is that we are giving something. If my patient is not at all fluid responsive, we cannot take it out. So we can induce the congestion or hypervolemia to the patient. So that's why another version of fluid challenge that is quite interesting, that is a passive leg rising. So in passive leg rising, where the transfer of blood from the legs and the abdominal compartment directly happens, central compartment, it will mimics the fluid challenge. It is an auto transmission of the blood volume. We don't need to give any fluid from extra from outside. Unlike fluid challenge, no fluid infused, and effects are quite reversible. If we change the position, it will be reversed. The hemodynamic response to PLR can predict hemodynamic response to the volume infusion. This is how we should, this is a diagram showing how to do the PLR. The patient should be at 45-degree propped up position and check the cardiac output at that position. It's the baseline cardiac output. Then make the patient horizontal, this position, and measure the cardiac output after 1 minute of keep in this position. Then again reverse the patient to the original position like 45-degree propped up, again measure the cardiac output in after a minute. So the changes from 1 to 4, here we'll change, see the change of cardiac output percentage of increase. So cardiac output should increase at that time at least more than 10%. And again, when we are making the patient propped up, the cardiac output again will go down to the baseline value. And then we can give the expected volume and see the practically the cardiac output changes. So this is a way of PLR, but it needed use real-time measurement of the cardiac output. Or else we can also see the changes in the VTI by real time, like more than 10%, also quite accurate with the measuring the fluid responsiveness in passive leg rising test. So what is good about the PLR? PLR has a good, it does not depends on whether patient is on a ventilation or not, whether patient is continuously ventilated, continuous respiration or not. It does not depend on the arrhythmia, and it is quite safe to do. Only thing, it can be falsely negative in patient with intra-abdominal hypertension, and it should not, it is quite relative contraindication in the patient who having other injuries like a head injury patient. But only thing, we need a real-time cardiac output monitoring to assess the effect of the passive leg rising. Now come to the IVC. That is a very commonly used in intensive care unit. The one is the IVC collapsibility. So IVC collapsibility is used for the patient who is on spontaneously breathing, not on mechanical ventilation. Here we check the maximum minus minimum divided by the maximum. If it is more than 50%, may predict increase in the cardiac output after the fluid challenge. But when the patient on mechanical ventilation, here we need to check about the distensibility index of the IVC, not the collapsibility, where maximum minus minimum divided by the minimum. If it is more than 18%, therefore 90% sensitivity, specificity, and identify the fluid responders. So This is how we measure the IVC, the M mode, which check the maximum and minimum diameter. So what are the factors can affect the IVC variations? Like again, intra-abdominal hypertension, very high respiratory drive, which can make the IVC falsely collapsing, cardiac arrhythmia, cardiac valvular pathology like severe tricuspid regurgitation, where you won't find the IVC collapsibility, or PH and IVC thrombus, and any other anatomical changes where you cannot use the IVC. Now come to the LVOT VTI. It is a very interesting, very good echocardiographic tool used daily in intensive care units, like measuring the velocity of the blood flow through the left ventricular outflow tract during the systolic. And after that, we multiply that VTI with the aortic root cross-sectional diameter to find out the stroke volume. Only the change in the VTI also with the respiratory cycle, if it is more than 12%, can predict the fluid responsiveness. So this is the conceptual basis of the VTI calculations, and it is a aortic root diameter we measure here. And now if you put it all together, multiplication, you can get the stroke volume and multiply the heart, will get the cardiac output. This is a picture showing aortic root area, and it is a apical 5-chamber view. You can put it, stress the VTI, you can get it. So again, with the VTI, as we can measure the stroke volume, we can also check the stroke volume variation even with the VTI if we don't have that high-end cardiac output monitoring devices in the setup. Few echocardiographic findings that can help us in the assessment of fluid responsiveness. One of the respiratory variation of aortic maximal velocity. If it is more than 10% during tidal ventilation and mechanical ventilator, this is a very good predictive value of fluid responsiveness. Now, LV size, as I already mentioned, is a left ventricular indiastolic area. If it is pretty low, it is quite, you can give the fluid, but it is also static variables. LV filling pressures, if it is more like restrictive mitral inflow pattern, where we should be cautious about giving the fluid. Most of the patients are not very fluid responsive in this patients. Now, right ventricle, the assessment of right ventricle is very crucial in critical care. If the right ventricular size is more than left ventricle, could be more than 1, and is grossly dilated, this patient usually all are fluid, mostly the fluid non-responders, who may need to increase the cardiac output by means of other inotropes, and rather we may need to take out the fluids by giving the diuretics. Showing like that. Now, regarding the right ventricular assessment, is very important is the D sign. The interventricular septum becomes straightening because of the right ventricular pressure or the volume overload. So we can differentiate on this by measurement of the eccentricity index. If the patient with the pressure overload of the right ventricle, where in the systole this index will be more than 1, and diastole also it will remain more than 1. But in the volume overload patient, if we give more of a volume, eccentricity index in the systole will be normal, but in diastole will be more than 1. Why it is important in volume overload and pressure overload, both the cases, in volume overload, we need to actively take out the fluid. In pressure overload, maybe the patient is having pulmonary artery hypertension or some pulmonary thromboembolism earlier. So it may not be the patient may remain the volume deficit also. In that case, it can also happen. But both the cases, in volume overload, it cannot give any fluid, and rather we need to take out the fluid actively. After the assessment of fluid responsiveness, the term I wanted to introduce here is the fluid tolerance, because it is very important. We all know the fluid responsiveness and fluid tolerance is a little different. Here, the ability of the body to receive the fluid without causing any organ dysfunction. Because if you give more and more fluid, going to become intolerant, the venous pressure will increase, and that will decrease the gradient of the pressure from arterioles to the vein, and it will further affect our capillaries in the tissue level. So this is a schematic diagram where you can see the decreased transcapillary driving pressure will happen if the venous pressure got elevated in patients who are intolerant to the fluid. So in this picture, you can see as more and more the venous pressure will increase, the more fluid it comes accumulated in the interstitium. Later on, if it is increased more, it will leading to tamponade of the capillaries, and later on also tamponade of the lymphatics, leading to the persistent edema of the body. And this tissue edema becomes very difficult. Lots of times we face to take out the fluid out of the body, because they all are accumulated. Maybe the patient becomes in the meantime hypovolemic intravascularly, but extravascular fluid accumulation remains so high, it will lead into the tissue hypoperfusion at that particular area. So there is a quick review of the relation of fluid responsive and the tolerance, where we can see any patient is fluid responsive and fluid tolerant, we can give the fluid liberally. But if they are not fluid tolerant, we need to either use a vasopressor or we need to take out the extra water. Maybe they are on the overloaded patient. So these are the effects of fluid of the congestion. I don't want to go in detail in the various organs they have mentioned here. And an important the kidney, liver, intestine. So now, how will you assess the fluid tolerance? The right side of fluid tolerance assessment, the left side. So it has been presented like that. We always see as a whole, like more in the CVPs, more in the global diastolic volume, IVC more than 2. Another is a VIXA score, is a venous extended ultrasound score, is used to predict, to assess the congestion or fluid tolerance of the patient. The left-sided parameters, we can see extravascular lung water, pulmonary occlusion pressure, pulmonary LV, filling pressure. If they are high, the patient is intolerant. Regarding little bit about the global diastolic volume, it is only this can be achieved. We can get this parameter if you use some high-end cardiac output monitoring. This is a transpulmonary thermodilation techniques, where we'll get the global diastolic volume by the sum of diastolic volume of the all heart chambers, and from there we can get the total intrathoracic blood volume, and then comes the extravascular lung water. It is very important. It's the water that is accumulated in the lungs, in the interstitium. So it is a difference between intrathoracic thermal volume minus intrathoracic blood volume. So there is a relationship. Normally, extravascular lung volume is corresponds to the pulmonary blood volume, but extravascular is a normal range. It is normal range is usually is less than 10, but it is more than 10. It means the volume inside the lungs are pretty high, fluids. So we cannot be give fluid extra to this patient. So this extravascular lung water can increase. That's the cardiogenic patients, the cardiogenic pulmonary edema, or maybe the non-cardiogenic, where the permeability is increased. How we can determine? We can determine with the pulmonary vascular permeability index. It is a ratio between extravascular lung water divided by the pulmonary blood volume. If it is elevated, if the PVPI is less than 2, it is mostly the cardiogenic edema. If it is more than 2, it's non-cardiogenic edema. In cardiogenic edema, we can take out the water by diuresis. It can reduce. But non-cardiogenic edema, it may be the disease process, like ARDS. When it is resolved, then only it will reduce. Because in non-cardiogenic pulmonary edema, if my patient comes as a fluid responsive, we have to give the fluid. But in cardiogenic, we have already determined we don't need to give the fluid. So any patient is hemodynamic and unstable should assess the fluid responsive. Then we assess the tolerance. If it is no, then do not administer fluid. Use a vasopressor or ionotrope. If yes, we can use a volume expansion. Little bit about the VEXAS. It is a non-invasive bedside tool to assess the systemic venous congestion. It is a very good correlation with the renal dysfunction after cardiac surgery, and useful tool to predict the hospital mortality in acute decompensated heart failure patients. So what is done here actually? You assess the inferior vena cava, then you assess the liver hepatic veins, the liver window, gut window, you assess the portal veins through the portal veins, and the kidney, you assess the internal veins. So in the IVC assessment, if the IVC is more than equal to 2, then it corresponds patient is congestion is there, and now we'll grade the congestion based on the congestion present in the hepatic, gut, or the kidney window. So now the hepatic vein, we should check the hepatic vein here as a connection between the IVC and the hepatic vein. We put the color Doppler. Then we'll put the pulse wave Doppler. We see the waveform. Like this is the waveform picture. So now if we go to the waves, A wave, S wave, B, and D. These are the 4 waves of the hepatic vein. And A is a positive wave, and rest all S and B are the positive wave, A and B, and S and D are the negative waves, and we get to the heart. So if I put it in this chart, it's very nice. A wave is correspond to the P wave is equal to the CVP A wave. S wave aligns to the QRS complex is correspond to the X descent of CVP. B wave is the end of systole. It's just like a CVP P wave, and D wave is taken place after the T. It is a diastolic wave. This corresponds to the Y descent. So now, normally S wave is more than the D wave, but congestion if it is increased, S become less than D, and severe congestion, it will reversal of the S wave will happen. Again, in the portal vein, also, if we find the porta hepatis from the portal vein, it looks like a color Doppler is a brilliant color because of the direction of the flow. Now we'll put the color Doppler here. Portal vein has a no specific waveform; it has a continuous flow. But if the portal vein shows some pulsatility, it means patient is having a overt congestion. Now this pulsatility less than 30 is normal. If it is more 30 to 50, it's mild. More than 50, it's called a severe congestion. Come to the renal window. Here we'll see the interlobar vein, and we'll put that color Doppler here. And after that, we'll put that pulse wave Doppler, the interrenal vessels, and above we can see the arterial waveform, systolic and diastolic, and below we get the continuous flow is the venous waveform. Again, the same principle. When there is a congestion, venous waveform flow will be interrupted. It looks like a pulsatile. So when there is a mild congestion, we'll get the biphasic wave like S and D waves interrupted in between, and the severe there will be completely monophasic only D wave only. Now this is a scoring system. Anyone having a IVC more than 2 and any combo of normal waveform or mildly abnormal pattern will be grade 1. Anyone having a one severe pattern, any of the rest of the window will be have a grade 2 and more than 2. If we are having a more than equal to 2 severe waveform pattern will be the grade 3. Grade 2 and grade 3 very well correlated with the cardiac renal dysfunction of the cardiac surgery and also the increased mortality in the acute decompensated cardiac heart failure patient in the intensive care unit. So this is the ultrasound flow chart evaluating the volume status. One is side will assess the fluid responsiveness. One side we should assess the fluid tolerance. Then we'll decide about the fluid therapy, whether to give it or whether to take out the fluid. This is the echocardiographic flow chart. So my patient is fluid responsive or not. So now we see the signs of overt hypovolemia, like small size LV, hyperdynamic, RV small, IVC is collapse, dynamic LVD obstruction. If any of it is yes, we can give the fluid challenge and see the changes in stroke volume or pulse pressure with that. If it is no, now the patient is invasively ventilated, sinus rhythm, tidal volume is okay, no spontaneous, we should look for the dynamic variables that we discussed, like pulse pressure variation, stroke volume variations, IVC respiratory variation. If the patient is spontaneously breathing, arrhythmia, severely dilated LV or RV, we should check for the passive leg raising test. That is quite validated in this scenario. If this is positive, we can give fluid and check again the fluid responsiveness. If any time the rise of stroke volume, cardiac output or VTI, if it is not more than 10 or 15%, we should stop giving fluid. Rather, we should consider taking off the fluid and addition of the suppressor or inotropes to manage the shock state of the patient. So conclusion, I will say the fluid management in patient with impaired cardiac function is very complex. And it's important to identify the subtypes of cardiogenic shock and the etiology, because not all cardiogenic shock patients are fluid depleted, or maybe they are presented with the fluid overload state. Later on, when the shock is dissolving, may land up into the hypovolemic state. And sometimes we get the mix, the patient who have a cardiogenic shock on top of that infection leading to the septic shock. So at that time, we can have it both. So we'll need, in these cases, we'll be very cautious to giving fluid and taking out the fluid. Fluid boluses should be titrated whenever we are giving the fluid any patient, irrespective of the cardiac patient. Also, the endpoint should be targeted and use of dynamic variables and echocardiographic assessment should be done. PA catheter, we all know, is a gold standard in assessment of hemodynamics, but currently this minimally invasive, non-invasive model is also quite good and providing information without any high risk. So our main goal in fluid therapy in any patient in cardiogenic shock or with the low ejection fraction should be maintain the balance between fluid responsiveness and fluid intolerance. We should give the fluid cautiously and we should also take out the fluid cautiously. Otherwise, we'll ultimately hamper the overall tissue perfusion and that leads to the further complication in this patient. Thank you.
Thank you, Devajyoti, for this very exhaustive discussion on fluid management in patients with heart failure, particularly HFrEF.
Yes.
This is open for discussion. Any questions, comments from the participants?
And there was just that it was an exhaustive lecture. But the important part of it is that there is sophistication and ground reality shaking hands in fighting heart failure. This is something very new. We came to know about PLR.
Yes.
That is also very interesting. And whatever will be the treatment or investigation, JVP and clinical assessment remains very high. And that is something very importantly we have stressed. I have one question.
Yes.
There is a trial known as PUSH trial, where they have measured the natriuresis along with diuresis. And is there any difference between the two if the natriuresis is high, say spot urine more than 17 millimole of sodium or less than that?
So actually, with most of the cardiac chronic heart failure patients, more they become congestion, we always think about that they maybe the fluid is more, but the fluid is more because of they may have the high sodium content. So that's why the blood osmolality and the urine osmolality comes to a play in between. So if we take out the more sodium in this sort of patient chronically, we can get rid of the fluid also. So, but when in a critically ill patient, it's practically speaking, sir, it's become very difficult. So if someone is on failure and requiring a ventilation or NIV, we cannot make this minute adjustment over there. But chronically patients we see like in the ward setting patients were more or less stable, but having a edema in all over the body and the lungs. The sodium restriction comes to a major role rather than the volume restriction grossly. Because we can reduce the sodium restriction, can take out the extra sodium, the volume will automatically will be reduced in those patients. So that's why the diuretics and sodium restriction is already there.
Devajit, I'll ask you a very practical question, but though this is little away from the main topic.
Okay.
Very often in patients who are having a reduced ejection fraction, we come across prescriptions, fluid restriction, 1200 ml per day, ejection fraction 40%. Is there any basis for this type of a prescription, or we should incorporate the symptoms, whether the patient is dyspneic or hypovolemic or volume overloaded? These issues should be considered more rather than just an ejection fraction of 40%, reduce this thing to volume total intake to 1200 ml.
Yes, sir. So you nicely said the latter part actually. So this fluid assessment, the fluid inside the body, these movements and everything is pretty dynamic. So and every individual should be assessed individually. Currently, we cannot make a one size fit for every patient. We should assess the patient. Ejection fraction may be low, but that does not mean the patient is overloaded. Maybe the patient maybe in the optimally evolemic state, or optimally maybe the patient is maybe the hypovolemic state also be there. We have found ejection fraction is less. That's why, sir, I put that slide about the fluid tolerance part. So only getting one eco factor like ejection fraction and restricting the fluid, I don't think it is quite all the time justifiable. We should take is a dynamic parameter. How is my patient doing? We can liberalize, increase the fluid intake also. On the top of that, when the patient is in the hospital, we have a liberty. We can assess the patient every day and a lots of time. But when they discharged home, we can train the caregiver also to look at the patient whether symptoms are any congestion is there or not.
Right.
And mostly, sir, restricting the fluids in an arbitrary amount, it's become very difficult in certain situations. Like we face lots of time in ICU, patient is around 80 years, 75 years, having some urinary tract infection. Intake becomes pretty low for last 5 or 7 days. They come in a shock in our ICU. Ejection fraction say around 40%, 38%. As the fluid is restricted, nobody dare to give the fluid. So at that time, we use the bedside echocardiography and echo findings, and we give the fluid to this patient, and they recover from that part. So
Right.
one size does not fit for everything, and we should assess this dynamic nature of the fluid shifting in every patient.
Any other question, Arindam, Avik, anybody?
Devajyoti, can you unshare your screen so that we can see each other nicely?
Unshare, right? Stop. Okay. Yeah.
Thank you.
Sorry. Thank you.
Fantastic presentation. So, which
Oh,
hospital you are working?
Fortis. Fortis.
Oh. Good to know. So, fantastic presentation. I must congratulate you. So, heart failure, when they hospitalize, cardiologists take their hands off. First thing they do, at least I do that, I take my hands off because they're very bad kind of people. There is very high in-hospital mortality rate. So, let me ask you, you showed many parameters.
Yes.
Do you apply them really, or you are just showing them for the sake of presentation?
No. Yeah. Be honest, not everything I apply. The one thing that I apply and every day is a bedside focus. We do that conventional echocardiography that's done. We assess that. I said the last part Vexus. I wanted to introduce it because this Vexus gives a lots of time very good idea. We encounter very time that Ghosh has said the ejection fraction is around 35-40%. Patient is in shock and leading into the your renal failure. We have seen there's a real life. I don't have that all data actually. This is elderly women. So she landed up into the dialysis. We saw the Vexus is around more than Vexus score 3. We do that very frequent dialysis to take out the extra water. What happened when this venous congestion completely goes away? She start urinating. Later on, she went home without any maintenance dialysis. So assessment of congestion part we do every day, and also the left ventricular VTI assessment whether it is changes, and this dynamic variation that we in our ICU have the monitor like pulse pressure and variations. We can adjust over there. Who are in intubated, we use it everyday tool for the fluid therapy. But these thermodilation techniques, we rarely use it because the cost is a hindrance. We have that machines, but we cannot use this. But though internationally they're quite recommended in mixed shock patients, we should use that EV1000 where we can get the full cardiac output continuously monitoring and extravascular lung water. But the extravascular lung water we cannot see in our ICU, but we assess it by the lung ultrasound. So we do it every day in all sick patients. So by this
So
way,
there is something known as impedance, lung impedance. By that, you can accurately assess the lung congestion.
yes.
So all the modern devices, CRT, ICD, CRT-D, they have this inbuilt facility. In fact, the modern pacemakers, they are little more expensive, but they have this device known as lung impedance. So by that, you can actually assess the fluid overload in the lung. That is very important because congestion as a whole doesn't mean anything. Whether the congestion is affecting the lung, that means the left heart failure or right heart failure. That has huge, difference in the therapeutic intervention. Do you use anything to measure the lung impedance? Because I assume that, patients who are getting admitted with heart failure kind of situation, many a time it's very difficult to differentiate between heart failure and lung cause. You can do NT-proBNP, but NT-proBNP have many fallacies. You cannot actually pinpoint, is it the lung congestion which is responsible for the presentation, the shortness of breath, the ventilation, whatever it is, or it is something else. So do you use lung impedance or something like that in your practice?
We don't have any other modalities to measure the lung impedance in our ICU. That's why we based on the lung ultrasound, where if you do the lung ultrasound, if you don't have this, that we use, where we can differentiate from cardiogenic pulmonary edema, why it is an ARDS. Simply by not the B lines, if you could assess the visceral pleural lining, that's if it is very smooth, mostly it is a cardiogenic. If it is ragged or irregular, Like if you do a lung ultrasound in ILD patient and lung ultrasound in overtly pulmonary edema patient, initially you won't find any difference. Both look same, the completely white, lots of B lines are there. But where we need to do the glitch is that you need to look into that pleural lining, visceral pleura. With that, you can differentiate whether it is a cardiogenic cause or maybe the pulmonary itself. But honestly speaking, we don't use the lung impedance till now. We don't have, I don't know how to use it with the CRTD, being honest. I have
Yeah,
never used
CRTD,
it.
you can just ask the, the people from the company people, they will
Okay.
come and interrogate it.
It is
They
based
will
on
give-
some plethysmographic technique.
Yes, sir. Yes, sir. You're absolutely right. But modern, all the devices, ICD or CRT, even the modern pacemaker do have this, facility to calculate the lung impedance. So this is very good. But the problem is you can also assess it by doing X-ray. If you find bilateral pleural effusion, then definitely it is, lung,
Mostly,
heart
yes,
cause.
yes.
Yeah.
Hard cause.
But the problem with this X-ray and ultrasound will have this idea, at a very pretty advanced stage. But if you really want to pick it up at an early stage, then you need to use lung impedance. So if I give you option of having a, device which can actually monitor the lung impedance, because I'm part of one of the startup,
Okay.
which is a device. Uh, this can actually give you the temperature of the patient, the saturation of the patient, blood pressure, heart rate, one lead ECG, and lung impedance. So, is it going to make some difference in the outcome of the
Yes,
patient? You
yes,
feel
as
that?
you say that, though I have not used that lung impedance, I will be very thank you for giving me that knowledge about that lung impedance.
Yeah.
Obviously, if we can get it about this lung impedance measurement, it can ease our way of managing the patient, obviously.
Yes, it's
Yes.
very important. So, exactly,
Because we will
I
get some objective data, I guess. Objective data is
No, no,
always
no.
better than the
So for that,
subjective.
I need your help because I'm part of, developing a, startup device. So
Okay.
really, I'll be very, very appreciating that if you become a part of the clinical trial. So I'll definitely contact you. Avik, please give
Okay, okay.
me
Thank you.
number because there is a device I have asked them. I'm part of the startup. So
Okay.
this device will calculate all these parameters. Most important is the lung impedance because all the other parameter you can calculate. Basically, the idea of developing this device is to monitor the patient post discharge to
Yes.
detect early deterioration. But I feel this is the enormous scope of this device in ICU because lung impedance is something which actually is ignored. And that is extremely important because NT-proBNP has many fallacies, many
Yeah,
fallacies.
that's quite variable
But,
also.
So
but
if you can directly calculate the lung impedance, you can differentiate between lung cause and heart cause, and you can actually direct your therapy accordingly. So I'll definitely contact you because we are in the planning of rollout of the trials, clinical trials. Definitely, you may be a part of it. I'll
Okay.
contact you.
I'll appreciate that.
yeah,
Obviously.
lung
You,
impedance, just a minute. Lung impedance is definitely a very important issue. But the claim of the CRTD and other pacemakers having sensitive receptor to assess lung impedance have not shown any benefit over the last 5 to 10 years. They have been trying that. If you have some newer methods of studying lung impedance, that is going to definitely of great help.
okay, thank
I
you, Anjan.
agree with you. I agree with your point, sir. So just to mention, problem is there is a concept of home monitoring, continuous monitoring of the devices. So problem in India, we do not do that. Remote monitoring of the cardiac devices. So if we actually go ahead with remote monitoring of the cardiac devices, which have this facility of monitoring lung impedance, which can actually calculate the fluid overload in the lung, then that will give the benefit because that will prevent many hospitalization, and hospitalization is directly correlated with the mortality of the patient. So problem is that it has to be incorporated in the system. Either it should be a Bluetooth device. By that, it is monitored by a third party, which is seeing the differences in the changes so that the patient can be communicated and his diuretic dose and any other precipitating factor can be taken care of. But that is not the case, because India is the country which uses the devices to the maximum tune, but home monitoring or the continuous remote monitoring is hardly used. That is the problem.
Okay, thank you very much. I think we need to end. It is already 10 minutes past 10. Thank you.
All good things should come to an end.
Yeah. And
Thank you, sir.
let us conclude it today. And Avik, I request you to organize a similar meeting for the next month.
Yes, sir. And thank you, Devajyoti. It was a very lucid and very extensively discussed talk. And Aurindamda, as usual, you have been excellent. Thank you.
Thank you very much.
Thank you.
Okay.
Good
Thank
night,
you.
everyone.
Good night. Good night. Everyone.
Bye-bye. Good night.